Greetings and welcome to session 6 of the Lurie Children's Pediatric Virtual Roundtable Series with the Potocsnak Family Division of Adolescent and Young Adult Medicine. My name is Chad Worley. I've been your moderator for this series. I am the Lurie Children's Physician Liaison for the north side of the city, north and northwest suburbs. I am joined by my colleagues, physician liaison colleagues, I should say, Paula Nowak and Julie Kalkbrenner. In the sixth and final session, we will be introducing you to Dr. Jessica Feuerstein, and she'll be talking about contraception for the primary care physicians. The Potocsnak Family Division of Adolescent and Young Adult Medicine at Lurie Children provides comprehensive services to adolescents and young adults. We accept new patients between the ages of 12 and 22 years. All patients are followed until their 25th birthday. Before I turn it over to Dr. Feuerstein, I would like to remind you that this session is being recorded, and we encourage engagement throughout all of our sessions through the series. You guys have been great with asking questions. Just go ahead and type them into the Q&A section, and we will answer them after the presentation. Unfortunately, due to the large amount of people attending, we can't take raised hand questions and answer them live. So again, please type them in and we'll answer the best we can. So I'd like to go ahead and now just turn it over to Dr. Feuerstein. You go ahead and take the screen. I'll stop sharing and it's all yours.
Awesome. Thank you, Chad, and everyone today for tuning in. Just going to pull up my slides.
Looks good.
Awesome. Thank you.
Sounds good. So go ahead, have at it.
Thank you. So today I'll be reviewing contraception for adolescents in the primary care setting. So you can think of this as a quick 20-minute crash course on reproductive health. So just to review today's goals and objectives. So we're going to develop a framework to understand why reproductive health care is critically important. We're going to list 2 highly effective contraceptive methods and recognize the benefits and risks of various other contraceptive methods. We're going to develop a proficiency in prescribing contraception, as well as become familiar with clinical tools to aid in contraceptive counseling, and as well as when and where to refer for services. So I want to start with just a background about reproductive health care and the term reproductive justice. So Sister Song defines reproductive justice as the human right to maintain personal bodily autonomy, have children, not have children, and parent those children we have in safe and sustainable communities. Reproductive health care is a state of complete physical and mental and social well-being, and not merely the absence of disease in all matters relating to the reproductive system and to its function and processes. So this implies that people are able to have satisfying and safe sex lives, and that they're able to have the ability to reproduce and the freedom to decide if and when and how to do so. So this brings me to my next point, that most teen pregnancies are unintended. Many just do not have the access to information and services to delay or avoid pregnancy. We know that parenting can be particularly, adolescents are actually less likely to finish high school when they're a teen parent, and more likely to need public assistance and have low incomes as adults, and have kids who face similar challenges. So poor education, behavioral, and health outcomes for those kids as well. Teen birth rates in the US have declined almost continuously since the early 1990s. But despite this climb, the US teen birth rate is still higher than many of other developed countries, including Canada and the UK. So this is all to say that contraception becomes a critical step for adolescents who do not desire pregnancy. So in 2014, the American Academy of Pediatrics released a policy statement, which included guidelines on all of reproductive and sexual health, but we'll focus in on the guidelines for contraception for adolescents. It advised those caring for adolescents to regularly update their adolescent patients' sexual histories on judgmental settings, which can be used to address the need for contraception. It also addressed allowing the adolescent to consent to contraceptive care and to control the disclosure of this information within the state and federal laws, which we know can vary across the country. It also advised healthcare providers who care for adolescents to have a working knowledge of the different combined hormonal methods and regimens for contraception and counsel about those methods from most efficacious to least efficacious. So we'll go through kind of what that order is, but LARCs, long-acting reversible contraception, being considered first-line contraceptive choices for adolescents. And if those providers were not able to perform those procedures, identifying healthcare providers in their communities who patients can then be referred. So as seen in this Venn diagram, when considering contraception, there should be a combination of individual counseling with shared decision-making. So it's not just us telling the patient what we think is best, but listening to our patient in front of us and sharing that decision together. So in general, when discussing contraception with an adolescent, it's vital that the healthcare provider make it normal, accessible, and confidential. Ask very open-ended questions and not leading questions. Make the room for ongoing conversation. So just because we're here talking about it today does not mean that we need to make a decision today, and this is not the ultimate or final decision. These decisions can change over the course of a teenager's life. I like to practice how I'm going to have these conversations with teenagers. It can be a little bit uncomfortable at times, especially when parents are involved. You want to make sure you're saying the right thing. So that's always something that I advise pediatricians to do when having. And also, I like to explore the role of parents or adult figures in our teenagers' life. So this is actually a direct quote that I use at almost all of my patient visits, at least when I'm talking about contraception, and it identifies the idea of consent and non-coercion. So I like to say, I'm here to help you decide which birth control is a good fit for you right now. So what's right for you might be different than what's right for your mom, your sister, your cousin, or your friends. And this decision about starting or stopping a method, it's yours to make. I think it's really important to identify your patient's goals before you even go through what types of contraception exist or what we think would be a good fit. I like to ask questions about what's important to my patient about their birth control. What are they looking for in a contraceptive method? What are you thinking about? And what kind of things have you already heard? A lot of the decisions that teenagers make happen to be influenced by their peer groups or what they hear online or in social media. So addressing those things in the beginning can be particularly helpful in directing those conversations. So this is something that I like to mention also when I'm talking about contraception, and I actually do it with both parents and patient in the room to mostly normalize the idea that contraception is not just for birth control, for preventing unintended pregnancy. So I like to say that we use it for so many different conditions. It's a medication that can be used for birth control, but it could be used for irregular cycles, painful cycles, migraine headaches, something called polycystic ovary syndrome or endometriosis, even ovarian cysts, something as simple as pimples, as well as premenstrual dysphoric disorder. Like we said, we like to talk about the idea of what the patient has heard from their friends or the community around them. And I take this opportunity to dispel some myths about birth control. I find that a lot of the time, even when I'm the one kind of addressing the concerns about contraception, they come at me with like, I don't know if this is a good fit, or a lot of hesitancy. And sometimes it's because they have heard some of these myths. A lot of the things we've heard have been increased fear about future infertility, weight gain, possibly birth control causing cancer. the morning after pill specifically, but other forms of hormonal contraception causing abortion or even harming a developing fetus. And this is one that we hear from parents a lot. If my child starts birth control, it's going to decrease the age at her first sexual encounter. So this is a good time to reassure everyone, including the patient, including the parents, and make sure that all of their concerns are addressed early on. So it's important to obtain a detailed history before you start contraception. Things that I like to ask about are the patient's general menstrual history. So when did they have their first period? How often are they getting them? When was their last menstrual period? Any concerns that they have around their menses, painful menses, heavy menses, irregular menses, symptoms like acne or mood changes related to their menses. I also ask about any type of sexual activity. So I talk about the different types of partners that they have, what gender or genders are they attracted to, their last sexual encounter, the type of sex that they're having, and asking about any type of barrier methods like condoms. I ask them about their intention for pregnancy, and it's not to scare the patient, but more so to kind of put in a plug that things like emergency contraception exist outside of the scope of just birth control pills. That is something we can also provide for our patient history, very specifically any type of migraine headache, specifically with aura, or any type of neurological changes, any high blood pressure in this patient's history, and then about their family history. Is there a family history of blood clots? Did anyone in the family have strokes, pulmonary embolisms, DVTs, things like that? And then I also find out if they're on any medications like anti-epileptics that could possibly decrease the efficacy of a combined hormonal contraception. So the next two slides are a really helpful clinical tool that I use almost all the time when prescribing contraception. It's the CDC's medical eligibility criteria. They actually have this online for free, but also if you have a phone that has an app store, you can download their free CDC contraception app, and I find it so helpful. So as you can see, there are 4 tiers to the CDC's recommendation of different types of contraception for different medical conditions. The dark green being like the most safe and fully recommended, all the way to the number 4, which is the dark red color, being not recommended. So dark green or level 1 means that the CDC recommends that we use this method for that medical condition. The level 2 or light green means that the benefits do outweigh the risks, and generally we would recommend using this method. The light pink color is level 3, and that means that it's actually not recommended. Generally, we would not recommend using this method because the risks will outweigh the benefits. And the dark color, the dark red, is level 4, and that means do not use this method. It is not safe. And this is just a continuation. As you can see, it's a pretty long list. This is also a really awesome tool. It's from bedsider.org. And this is something that I use absolutely 100% of the time at every visit that I talk about contraception, whether the patient is just first learning about contraception or already knows about it and has been on one and wants to switch. And I go through it, and I like to hand it to the patient and the family when I'm talking about it so they can visualize what we're talking about. So I go through, there's the pill, the patch, the ring, the shot, there's an implant, an IUD, that's both hormonal and copper. So this chart is basically talking about the efficacy of different methods of all the various contraception methods for typical use and perfect use. And as you can see, the most effective methods rely least on the individual's adherence. So looking down at the bottom of the chart, both the IUD and the Nexplanon implant have very similar numbers for typical use and perfect use. And pediatricians are encouraged to counsel adolescents discussing those most efficacious methods first. So here's just a review again of all the different types of contraception that we'll be talking about today. We have the pill, both combined oral contraception, meaning estrogen and progesterone, or the progesterone only pill. There's the vaginal ring, there's the contraceptive patch, and there's the injection, which is called Depo-Provera. And then to the right, we have our LARCs, which stand for long-acting reversible contraception. And the blue side is the implant, and the purple side is the IUD. In general, both the implant and the IUD require that the provider be trained to insert and remove them. It's something that we do a lot of in our outpatient office. And we also have resources available for people who desire confidential LARC placement, such as Planned Parenthood, the Howard Brown Broadway Youth Center, Erie Health, and there's just other resources out there if a patient is super concerned that this is going to be like told to their parents. I think ultimately what I try to do when we're thinking about LARCs with patients is encourage their parents to be involved in that process as much as possible. So if a patient is concerned that it's going to out them in their sexual activity, we talk about the other indications for a LARC, and we have the parents involved in that conversation so that everyone is involved. In terms of referring for LARCs, I think it's important for general pediatricians to know which referral providers will provide LARCs with the most minimal barriers so that they have comfort in inserting both IUDs and implants and not requiring multiple visits. This is something that could be done in a few minutes, and it should be done the same day. It's also important in the primary care setting when we're referring for LARCs to bridge that form of contraception with something that can be started that same day in the primary care office. So whether that's the pill, the patch, the ring, or even the Depo shot, it's important that we give some form of contraception until the teen can actually make that appointment to access a LARC. Also, it's a good time to talk about emergency contraception and offer an advanced prescription. So Depo-Provera, it is every about 12-week injection, and it can be even given sooner if it's used for abnormal uterine bleeding or heavy menstrual bleeding. The way it works is it suppresses ovulation. It can also thin out the endometrium as well as thicken cervical mucus. You can really start it any time in someone's cycle. We say within about 5 days of menses to minimize the amount of breakthrough bleeding, but you can even start it the same day and it really does not matter. When you're administering Depo, it's important to counsel on the potential of irregular bleeding, which is most common between the first, second, and third shot. Usually after the third shot, we tell patients that at that point, ovulation is pretty much guaranteed to be suppressed, and there should be very little breakthrough bleeding at that point. This is actually the only form of contraception that the concern of weight gain has actually been found to be true. It's mostly like a water weight or fluid retention, but that is something that I always counsel patients on, and I never want anyone to be surprised after the fact. There is this reversible decrease in bone mineral density. This is something that I think about when I'm counseling about contraception. If somebody is prone to having fractures or has a history of multiple fractures, I consider not doing Depo for this reason, as well as a delay in return to fertility. So there's about an 18-month delay in return to fertility, meaning that the day we stop the Depo, it could take about 18 months for someone to become pregnant. So this is a big, busy chart of different types of oral contraceptive pills. I want to focus everyone on the fact that there are a lot of brands out there, and my recommendation and what I do is I just pick 1 or 2 pills that I'm comfortable with, and I stick to those when I'm prescribing oral contraception. So I recommend somewhere between like the 30 to 35 microgram ethinyl estradiol dose with a neutral, which is a 3rd generation progesterone. In general, monophasic pills are the best for teens, and that's what I always try to pick. And then we can talk about the ways that we can prescribe them, whether someone's going to take them cyclically, meaning they'll have a withdrawal bleed the week they take those placebo pills, that 4th row, or we can do it continuously for people who want menstrual suppression for various different reasons. And that would basically mean either skipping that 4th row or using a pack that doesn't have any placebo pills in them. when counseling patients about starting oral contraception, it's important to let them know about the possibilities. Things that I like to talk about are some GI upset, some nausea that usually resolves in about 2 weeks. Sometimes you can get headaches. If so, I want to know about them, especially if there's any form of aura or neurologic association. That would be a reason to stop any type of estrogen containing contraception. I always counsel on the risk of blood clots. So I talk about the warning signs or red flags for DVTs, for pulmonary embolism, and for stroke. And these are things that, you know, we talk about, and we have mom and dad and patient consent to it at that time. And if they're not comfortable, we discuss other non-estrogen containing contraception. So the estrogen containing contraception, we have our pills, our patch, and our ring. So we spoke a little bit about the pills. I'm going to go straight to the patch and the ring. For the patch, we have something that we change every week. And then on the 4th week, we can either have a period, or we can even skip this and put a patch back on. And that would be like a form of menstrual suppression. Some side effects are adhesive tape reaction and breakthrough bleeding. If they're having any of these things, we want to talk about it. We want to see if this is still their form of contraception of choice. And if not, recommend other types of contraception that they might be interested in. And then the ring. So there's 2 types of rings. There's one that we can keep it in for a month and remove it if you want to have a period that 4th week, or keep it in. And there's another ring that lasts for 1 year. And again, you could take it out every the end of every month for 7 days and have a withdrawal bleed, or you can keep it in. And the side effects of that we counsel are vaginal irritation and some discharge. So for those who cannot take estrogen containing contraception, I think about progesterone containing pills. So the 2 that we are most likely to prescribe are norethindrone, which is a 1st generation progesterone. And as you can see in the table to the right, those are actually quite androgenic. So agestin or norethindrone, it's continuous cycling, meaning there is no placebo, and it's a generic pill. We also have drospirenone, which is a little bit newer. This one goes by the name Slind. Slind does have a 4-day placebo where patients will get withdrawal bleeds. And right now there are no generics for this. Some of the side effects that I counsel with progesterone-only pills are breakthrough bleeding. Depending on the generation, you could have some androgenic symptoms like acne or hair growth. You can have changes to your cervical mucus and some mood changes as well. Lastly, I really wanted to just mention quickly emergency contraception, as this is something that we can keep stocked in our clinics for patients, but we should always also just talk about this with our patients. So there are a few options. The 2 pills are Plan B or Ella. Plan B is levonorgestrel, which is basically a very high dose of progesterone. It's 1 tablet, which inhibits ovulation. And this is FDA approved for the first 72 hours after unprotected sex. It's best if it's taken within the first 24 hours after unprotected sex. And we know that like further away we get from that, it's less efficacious. It's available over the counter, and if we prescribe it, it also, I think, might be free for some insurances like Medicaid. Unfortunately, it's not the best efficacy in somebody with a BMI greater than 25. And then Ella, it's also a 1 tablet pill. It inhibits ovulation by the mechanism of action later. This one is FDA approved for up to 5 days postcoital, and efficacy does not wane as you get further from that 24-hour point. This
Dr.
one does.
Feuerstein,
Oh,
I'm
yes.
I'm sorry to interrupt you, but you went silent on that one. Can you just last 10 seconds, just repeat the last?
Oh, yeah.
Thing you just
Sorry.
said? Thank you.
Absolutely. Thank you. Ella is also a tablet. Its mechanism of action, it's a progesterone receptor modulator, so it inhibits ovulation. This pill, Ella, it's FDA approved for 5 days postcoital. And unlike Plan B, Ella's efficacy does not wane the further you get from that 24-hour mark after unprotected sex. Ella does require prescription, and it's also better for people who are in BMI greater than 25. And lastly, I just want to talk also about the levonorgestrel IUD and the copper IUD and its use as emergency contraception. So either while or after prescribing emergency contraception, it's important to also offer an additional contraception that is more efficacious, like an IUD. So that's always a good choice. Emergency contraception and other contraceptive agents can be used as a bridge to LARC placement, which is also something really that we should be talking about at all of these contraception visits. And any discussion or prescription of contraception is better than nothing. So in summary, some take-home points are reproductive health care. It's critically important, and it's something that we should all be comfortable with discussing with our teens, and when necessary, their family. Various contraceptive options exist, and I like to use the clinical aids like bedsider.org and the CDC medical eligibility criteria to help decide the best option for my patient. OCPs can easily be prescribed in the primary care setting. And if a patient desires a LARC, which is an IUD or an implant, or has any confidential services that they are interested in, it's always important to know where to refer for care. I'm always happy to see those patients in our outpatient Lurie office, as well as actually at Broadway Youth Center. And like we said before, options like Planned Parenthood exist, Erie Health exist. And lastly, emergency contraception. It's important to discuss it with all teens whenever possible, stock it in our clinic, offer it at visits, and use emergency contraception plus another form of hormonal contraception to bridge for any type of LARC procedure. And that's it.
That was outstanding. Thank you. Can you just keep up your slide here?
Sure.
That way they have your email address if they want to ask you some questions. That was an excellent presentation. So thank you again for doing this. As a parent of a teenage daughter, I will tell you, there was some great takeaways for me on here. So thank you. But I think there's some questions in the chat room. I'm going to go ahead and let Julie take that away for you.
Thank you, Dr. Feuerstein. We just have a couple questions. What age or Tanner stage is too young to start seasonic or a method that skips a period?
Yeah, that's a great question. So I see that the question also elaborates for special population adolescent, i.e. autism. So this is something that we get a lot of referrals for patients who have some type of menstrual hygiene concern. I think menstrual suppression is definitely a good option and a good solution to a lot of these concerns. Once somebody starts having menses, I think it's totally fair if the benefits are outweighing the risks to start offering menstrual suppression. So options for that, if they can take oral contraception, i.e. pills, that would be a good choice. Depo-Provera is a great choice because that only requires a shot once every about 12 weeks. And yeah, something like a LARC would be also a really good idea if that is something that the patient can tolerate. And sometimes we even see patients doing this under sedation. Usually we're not sedating the patient just for the LARC, but if they have another procedure that requires anesthesia and they'll be sedated, we can try to coordinate to do those together.
Okay, so for the LARC implantation, just to clarify, you do that at the 2 sites you indicated. And does the consult, is that included in the appointment for the implantation?
Gotcha. So usually we aren't placing them the same day we're first meeting the patient. The reason is sometimes they come to us thinking that they want a LARC, and then we go through all the different forms of contraception, and it turns out maybe pills or a shot are better options for that patient's concerns. You know, I would love if I can place a LARC such as an Nexplanon implant, because it only takes like 30-40 seconds to place that same day. And certain situations we will, like if this is a patient where we're concerned for follow-up and I have time in my schedule, that is definitely something that I would try to do.
Okay, and do you do any of that consultation through telemedicine?
Yeah, we absolutely use telemedicine.
Great. Okay. I think we have a couple more questions here. Are there options for localized anesthesia pain relief for IUD insertions?
So IUD, normally what we'll have patients do is we'll advise them to take some type of NSAID, ibuprofen, naproxen, about 30 minutes to an hour before the IUD is inserted. It's similar, the pain is similar to, like I say, their worst period cramps. So as long as they're able to tolerate like a speculum exam and kind of have their muscles relax during that time, I think the most pain is really just coming from the insertion of the IUD entering the uterus. And it's that cramping, like very bad abdominal pelvic pain. So it should help with just NSAIDs like any other painful period. But, you know, we say kind of take it for like the first few days around the clock every 6 hours while you're awake to kind of minimize that pain on a preventative side. Otherwise, we don't really give any type of local injections like lidocaine. We do lidocaine injections though when we're placing Nexplanon implants. So we'll insert like 2 milliliters of lidocaine under the skin when we're inserting an implant in the arm.
Okay, and then our last question is, do you avoid estrogen in sickle cell patients?
Ooh, great question. So for a question like that, I always, like I said, go to the medical eligibility criteria. So I would check that chart that has like those green, pink, and red shades. I would see if sickle cell is listed on there. Knowing that sickle cell patients are at increased risk of clotting, I think that would be something that I would just want to double, triple check that the CDC says estrogen containing products are okay. I have a feeling though that it would probably be like a level 3 or 4. So I'd try to counsel about progesterone only contraception in that group.
Great. Thanks, Dr. Feuerstein. That wraps up our questions section.
Awesome. And I included my email so everyone can feel free to reach out if anything were ever to come up.
And thank you for that. This was another great talk. And this will wrap up our virtual series. And after 6 sessions, I think it was very successful. A lot of you, I just want to say thank you. I know some of you have been out for every single session, and that's wonderful. And we appreciate your support. If you like what you see, we ask you to hit a like button here on this YouTube channel that you see. Also, you'll see links to the Adolescent Medicine page and also to our RAMP website. So if you need more information, you can click on those links as well. But I just want to do a special thank you to Dr. Montalto for putting this together, help us putting this together. Dr. Dar, Dr. Simons, Dr. Ramadar, Lindsay Eilers, Dr. Montalto again, Dr. Nelson, and of course you, Dr. Feuerstein, for being with us and really engaging with our pediatric healthcare providers here in the community. Our relationship with them is very important, and we really cherish it. And having this information for them is something that is invaluable. So on behalf of the Lurie Children's Physician Services team, thank you, and we look forward to seeing you again soon, and have a great day, everybody.